In this video, we will show you the technique of Hemi wedge osteotomy for the correction of severe tibial varus deformity with an MPTA of less than 80 degrees. To determine correction angle and wedge height, preoperative planning is performed according to the method stated by Miniaci. For the osteotomy, the knee is in a flexed position to protect the neurovascular structures. An approximately 10 cm long incision between the tibial tuberosity and the fibular head is made, and the peroneus nerve is exposed behind the fibular head. Then the extensor muscles are detached to expose the proximal tibia, and a wide radiolucent Hohmann retractor is placed behind the posterior tibial cortex. A second, smaller Hohmann retractor is placed between the patellar tendon and the tibial tuberosity. After exposure of the proximal tibia, a first ascending guide wire is drilled from the lateral to the medial cortex of the proximal tibia. Another guide wire is drilled slightly converging under the control of the image intensifier to mark the second osteotomy plane. This wire should meet the first wire in the middle of the tibia. After guide wire placement, the first osteotomy is performed below the upper guide wire, avoiding the tibial tuberosity. The medial cortex must be cut so that the osteotomy gate can open medially. Then, a second osteotomy is performed above the lower guide wire towards the middle of the first wire. Finally, an ascending osteotomy is carried out behind the tibial tuberosity. After removal of the bone wedge, valgus stress is applied to the tibia to close the lateral gap. If the medial cortex does not open because the osteotomy is still incomplete, wide Lambert chisels can be used to complete the osteotomy. After complete closure of the lateral osteotomy gap, the new mechanical axis is checked with a metal rod and an image intensifier. The aim is correct the new mechanical axis between 50 and 55% of the tibial joint line. Once the desired correction has been achieved, an anatomical locking plate is used for lateral orthosynthesis. First, the proximal screws of the plate should be placed 5 to 10 mm below the joint line. Then the orthosynthesis is completed with the distal screws. If some further correction is needed, the first distal screw should be a compression screw. The rehabilitation protocol includes partial weight bearing with 10 kg for 6 weeks and free range of motion. A postoperative long leg X-ray is recommended to control the new mechanical axis.